Hello, my name is Dr. Christopher Pieczonka. I'm a urologist and associated medical professionals, a group of almost 30 urologists in a multi-specialty practice in central New York. And today I want to talk about immune therapy in metastatic castrate-resistant prostate cancer patients and how our experience has been in a large urology group. One of the things I think that's important to realize is that 2013 is very different in terms of what is available for patients than what was available even in 2010. And castrate-resistant prostate cancer is previously been an area that most urologists did not want to treat patients in, and often would refer these patients to specialty centers or medical oncologists. And the world really changed in April of 2010 when Sipulous LT was approved by the FDA for the treatment of these patients. And there have been multiple medicines that have been approved since then that are urology friendly, for lack of a better term, and that urologists have been starting to utilize these medicines, feel comfortable with these medicines. And as a result, the purpose for discussing these medicines today is to really see if we can increase the educational awareness. So castrate-resistant prostate cancer often starts out with non-metastatic disease. And patients who have non-metastatic disease really don't have any standard therapy that's available to them. A lot of these patients would benefit from being on some sort of clinical protocol. Many people will put patients who are non-metastatic into secondary hormonal therapy. The problem is that secondary hormonal therapy really has no documented survival benefit. And when patients become metastatic, it's really a continuum. There are the patients that are metastatic and are asymptomatic, and patients become symptomatic. We give them chemotherapy, and then there's the group of patients and what we can do after chemotherapy has been given. And you can see in the metastatic patients who are chemotherapy naive and asymptomatic that there are a variety of different treatment options for them. I'm going to present a case in a little while for this kind of patient and discuss the options, including Sipulous LT, secondary hormonal manipulation, the usage of bone-tropic agents and abiraterone. Docetaxel is in parentheses. The reason for that is because the AUA suggests to be a patient that could be treated. The NCCN guidelines would suggest that docetaxel should be reserved for more advanced prostate cancer patients who are symptomatic. Symptomatic patients, you can see docetaxel in the newly approved radium-223. In the post-docetaxel space are some of the medicines listed there, including enzalutamide. However, most people feel that enzalutamide is likely going to get FDA approval to be treated in a pre-chemotherapy asymptomatic patient. This is a table of a variety of medicines that are listed that have shown some overall survival benefit in metastatic castrate-resistant prostate cancer. What I want to point out to you is that the median survival benefit is roughly 4 months, give or take, on these patients. And the reason that that doesn't appear to be much, and when urologists have heard that, I think some of them have sort of thought that doesn't do much for patients. However, 4 months of survival benefit in oncology circles is actually a big deal. And if you were to look at that relative to the expected survival on a patient with untreated metastatic castrate-resistant prostate cancer, 4 months is very important because the average life expectancy is anywhere from 16 to 21 months in these patients. What I want to point out is that the newly approved medicine treatment of abiraterone in the pre-chemotherapy disease space has documented some overall survival benefit, but it has not reached statistical significance. There are also a variety of clinical trials that have looked specifically at immune therapy only. Sipulous LT has had the IMPACT study, but there are some other, there was a study done prior to that, which was also a randomized prospective study. There's a study that used GVAX, and there's also the PROSPECT study. Of note regarding the PROSPECT study is to look at the overall survival in the phase 2, which was actually quite impressive. That PROSPECT study is now currently in phase 3 and accruing patients. I think it's important, though, to focus on the current role of immune therapy in prostate cancer is really the role of Sipulous LT, as this is the only approved medicine for treatment in prostate cancer from an immunotherapy standpoint. And what happens with Sipulous LT is that a leukapheresis needs to be done. Leukapheresis is a collection of white blood cells. I explain to my patients that the white blood cells are siphoned off by a fancy machine. Roughly 0.5%, less than 0.5% of the circulating white blood cells are taken off pieces. They're centrifuged and then actually sent to the manufacturing facility The Dendreon runs either in Atlanta or in California. In the manufacturing facility, these white blood cells are then exposed in a culture medium to a fusion protein of prostatic acid phosphatase fused to GM-CSF. This fusion protein then allows antigen uptake into antigen-presenting cells. The blood product is then intravenously administered back to the patient 3 days later, and the activated antigen-presenting cells then turn on the T cells, which then can seek out, identify prostate cancer cells and cause tumor lysis and tumor cell death. Of consequence with this is that, and what I want to point out is that the targeting agent of sipuleucel T is actually prostatic acid phosphatase, which is present in a higher percentage of prostate cancer cells than specific antigen or PSA. So what I will show here is a case presentation of the kind of patient that is typical in a lot of the urology practices that my colleagues will see. And this is the case of a 74-year-old white gentleman who had a radical prostatectomy done with lymph node dissection in 1992. His surgical pathology revealed Gleason 4+3=7 disease, and his lymph nodes were found to be positive. The patient then underwent a staged orchiectomy for treatment. At that point in time, the patient really did quite well for many years and then was found in 2008 to start to have a detectable PSA. He remained asymptomatic, however, and had excellent performance status. Over the next several years, the PSA continued to climb, and PSA was as high as 2.36 when he underwent some staging by one of my partners. He underwent a CAT scan, which was negative, and then a bone scan, which showed the possibility of a sclerotic area in the left fourth rib. He was then sent to myself, as I see most of the advanced prostate cancer patients in our practice, and I immediately thought it would be best to do a confirmatory sodium fluoride PET-CT scan. I'll explain the rationale behind that in a little bit. But this was performed, and it was really unsure whether or not the fourth rib that had some activity was metastatic or not, and the radiologist really was unsure. We decided to wait several months, and his PSA climbed even further. We then repeated his sodium fluoride scan, which really showed significant increased activity in that fourth rib as well as spots that were read to be metastatic, and we thought clearly that this patient had metastatic castrate-resistant disease. And one of the things I wanted to touch on is the importance of the sodium fluoride PET-CT scan and how this might change the overall dynamics for prostate cancer detection going forward from here. One of the things that I think is important is to realize that there are a variety of patients that may have metastatic disease with lower PSA. Dendreon has done some chart reviews, which is unpublished data, but this suggests out of a group of 1,100 patients that those with metastasis, that 55% of them have metastasis with a PSA less than 11. So I think that if you're not looking potentially with advanced screening techniques, you might miss occult malignancy. The, I think, first article that really showed the clinical utility of sodium fluoride scanning was this article as referenced below, which is a randomized prospective study in patients that had high-risk prostate cancer looking to see whether or not they had metastatic disease or not. And they were randomized to getting a technetium bone scan followed by a regular sodium fluoride PET scan versus a different group that had a technetium bone scan and then went on to have a sodium fluoride PET-CT scan. And as you can see out of the lesions that were detected, that the sensitivity and specificity on the sodium fluoride PET-CT scan was much higher than the technetium bone scan. I think that the reason that that's important is because the sodium fluoride PET-CT scan is available in many freestanding radiological facilities in the country. And more importantly, for our Medicare patients, the Medicare patients, as a rule, can get this study completely for free by agreeing to participate in a registry study that Medicare is performing to see how the sodium fluoride scan and its clinical utility. What you see on this particular graph is one of these patients who was randomized that had the traditional bone scan, and this particular patient was randomized to get the sodium fluoride PET-CT scan and follow-up. And essentially his bone scan was read as negative, but his PET-CT scan found a thoracic vertebrae that was simply missed by the bone scan. And in our own experience, I think that we've seen similar circumstances. And I believe fairly heavily in the sodium fluoride PET-CT scan, but must comment that you must have a radiologist that's comfortable reading them. So in terms of what we recommended to our patient, well, we try and do guideline-based medicine in our practice. And been using the NCCN guidelines at the point that we had the discussion with the patient. Several months ago, there were also AUA guidelines that were released, and they're similar in some ways but different in others. The NCCN guidelines would suggest in a patient like this that he be offered either Sipuleucel T or abiraterone. Both of these have Category 1 evidence in an asymptomatic patient. In terms of the AUA guidelines, this kind of patient would be similar to the index patient number 2, and the options that could be discussed were Sipuleucel T, abiraterone, or docetaxel. However, the AUA guidelines really list a general principle that it is preferable to give the least toxic agent first, particularly without the evidence of a lot of head-to-head data. And as a result, this patient was recommended, and he in fact elected for Sipuleucel T, and also was given Xgeva starting in January 2013. Actually, we started as Xgeva a little bit after the Sipuleucel T was administered. What we did then is we repeated a sodium fluoride scan. We usually repeat these anywhere from 3 to 6 months, in which case the sodium fluoride scan done after CYP-T administration showed that there was some disappearance of the lesion in the right mastoid. And the radiologist at least suggested the possibility that tumor lysis had occurred. And one of the reasons for that is we also noticed that his PSA had actually decreased or gone down. So I think it's important to discuss why we think immune therapy first might be the best option. And according to tumor biology rules, the faster growing tumors will lead to reduced survival. And the group from the NCI recently proposed a kinetic model of tumor that might explain why we would want to use immune therapy first. Number one is that it appears that immune-based treatments may slow the tumor growth rate over time, over, quite frankly, an extended period of time. But what you might not see is significant decreased short-term tumor shrinkage and possible cell death. And the consequence for that is that patients treated with CYP-T may not have significant decrease in PSA. Though I've showed that as a possibility in our case, for the most part, when patients are treated with CYP-T, their PSA does not go down. On the contrary, any type of cytoreductive chemotherapy may cause cytotoxic cell death and a transient decrease in the tumor growth rates, and you might see actually PSA decrease. And one of the things that comes about with this is that it might be most prudent to use immune therapy combined with some sort of cytoreductive chemotherapy. This might allow a synergistic effect, and given immune therapy first might allow enough time for the potential slowing of the tumor growth to happen. And this is borne out on this graph again from the NCI, where you look at the red line, which is the immune therapy line, and you see that there is not a significant rapid decrease in tumor burden with immune therapy. It's more of a slow churn. It's sort of like just trying to put speed bumps in the way of this rapidly oncoming tumor. And what you see with cytoreductive therapy is that you might see cell death, maybe see decreased PSA, but it appears as though the immune therapy might be better long term. And the green line is the theoretical line that shows that combination therapy, because the mechanisms of actions of both of these are really separate from one another, may be better. And this is going to be studied in a variety of different combination sequencing studies that are going to be started soon. So really the question is then what do we have now? A lot of this is theoretical, but what can you counsel the patient about now? One of which is the quartile data, and the quartile data is data that Shellhammer et al. Presented at ASCO and has now been published recently. And they retrospectively looked at the patients who were in the IMPACT study. The IMPACT study is the study that was done by Dendreon to facilitate Sipuleucel T approval, and it was a prospective study. They retrospectively looked at these patients in the study and tried to identify the prognostic factors that would best correlate with overall survival. And it appeared that the treatment effect appeared greatest with CYP-T with a decreasing baseline PSA. And essentially, the patients who were estimated to have the best median survival of 13 months were in the lowest PSA quartile as defined by a PSA less than 22, and the patients in the highest PSA quartile, as defined as greater than 134 nanograms per milliliter, had the lowest overall survival. And the reason that that's important is that the estimated 3-year survival in the lowest PSA quartile was 62% versus 41% in the control patients, and that appeared to be a 50% relative increase. And this is a graph that basically shows what I've discussed previously, that if you look in the patients with the PSA that is in the lowest quartile, as defined by a PSA less than 22, their survival benefit is striking compared to those with a higher tumor burden, as evidenced by higher PSA. And what we did is then we tried to say, well, how does this apply to our own group of patients? And we used the same quartile definitions and the same PSA definitions in the first 50 patients that we've treated with sipulous LT. And this is data from earlier in the year, as we wanted to have some short-term follow-up in anticipation of doing this lecture. And what you can see here is that in sort of just layman's terms, that we have more patients alive with a lower PSA, potentially lower tumor burden, than those patients that are treated with more advanced disease. Looking at it a different way, if we were to look at our own data and then say, well, let's not use the impact quartile data, what would our quartile data be? And our quartile data is that 25% of our patients are treated with a PSA less than 3. And again, in a simple way of explaining this to patients is that the number or percent of patients that have died is simply lower than the patients with the lower PSA than the patients with the higher PSA. Now, I will admit to you that this is a small group, that there's limited follow-up, and this is completely retrospective. But I think that our own data appears to compare favorably to the data that Shellhammer presented. And I think the thing that's fundamentally most interesting about this is you have to look at when the impact study was performed and really where it was performed. And I would argue that the impact study were patients that were treated roughly anywhere from 7 to 10 years ago, mostly in academic medical centers, and the patients really had to worm their way through many, many different doctors to get there and to be put on protocol. Where in an average urology practice like ours, you're finding garden variety patients on the cusp of becoming non-metastatic to metastatic disease with lower PSAs that we potentially could treat and treat earlier. And I think that that's how a lot of other urologists could approach this, is to look for these patients to treat them earlier. So the question is really, why is this important? Well, really, other than the quartile data, we have nothing else that we can review with patients and tell them about how sipulous LT is going to benefit them. There currently is no immunologic available to monitor and predict the outcome of immunotherapy. And Dendreon is actively looking at this. They're looking at a study to look at the immune markers on patients who are enrolled in the PROCEED registry study and following them longitudinally and seeing what biomarkers would be available to correlate with overall survival, but currently we have nothing. And so the question is if you believe the quartile data, how does the immune response, in other words, what does the immune system do that might explain the trend that is seen in the overall survival with lower tumor burden? How does the immune system help with that? And I think that the immune response therapy really is this, is that the immune response might allow antigens to be exposed that were not specified with a certain vaccine. In other words, sipulous LT targets prostatic acid phosphatase and causes tumor necrosis. And with tumor necrosis, there can be a release of other antigens from the prostate cancer itself through a process that we call self or auto-vaccination. And these secondary antigens can then be processed by the immune system and then potentially used to help guide or kill other cancer cells. And these quote-unquote new cancer antigens are the ones that had been aberrant in the first place. They may be a product of some sort of mutation or amplification in the androgen receptor pathway that had been facilitating the signaling process that's allowed patients to progress despite castration. And in theory, this may contribute to the potential benefit, particularly if you treat a patient earlier, there may be more time, I should say, for the self or auto-vaccination to happen. So really, why is this important? Important for several reasons. Number one is that, as everyone knows, sipulous LT has had a rough acceptance and uptake amongst many clinicians. It's been a long road for Dendreon to get clinical acceptance on this medicine for a variety of reasons. A lot of that has been directed towards the criticism of only a 4-month survival advantage. But I think that our own clinical experience has shown that we are identifying patients much earlier in the disease than those who are treated in the pivotal study in IMPACT, and as a consequence on this, we would expect much better overall survival on these patients treated earlier. And the only way of explaining as to whether or not this is going to have significant improvement is some sort of combination or sequencing trial, which are going to be happening now and happening in the near future. And you can see that this is just a little cartoon showing a prostate cancer cell. In red are the variety of the medicines that are currently out or available on the market. Most of these medicines in red weren't even available or FDA approved a couple years ago. And time will tell the best combination of sequencing that will allow best survival on patients. And for that reason, there are a variety of ongoing clinical trials in immune therapy. There's ipilimumab studies, there's PROSPECT studies, a variety of different sipula cell T studies. One of the ones that's most exciting for a lot of clinicians is the upcoming sipula cell T with enzalutamide study. That is, I think, going to be very interesting when it finishes enrollment and the data is released. And really, my take-home messages on this would be as follows. Number one, if you're treating patients with prostate cancer, that if you're not actively screening for metastasis, you should be. And you shouldn't wait until the PSA is too high to start screening. The best screening technique would be a sodium fluoride scan if possible or if available. Number two, there is no current biomarker available to monitor treatment response to sipula cell T. As a result of that, then the question is what else can you use? And the quartile data can be potentially used to counsel patients about overall survival. The lower PSA appears to be better. Number four, the combination of CYP-T with other types of cytoreductive therapy may lead to a synergistic and enhanced immune response. Again, this remains to be seen, but it makes sense that if you have two different novel mechanisms of action, that there may be an additive effect. And the last message really is that further clinical trials using a combination approach is needed to try and identify the best therapy overall in these patients. Thank you very much for allowing me to participate and review this exciting disease state and clinical entity with you.